about this. It'll be an update of some of the data we presented at World Lung just a couple months ago also. Some new stuff, my disclosures. So I think it's important, and Ravi had mentioned this yesterday, that MET aberrant disease is not a homogeneous entity. We have MET mutations and amplification, which are probably distinct targets, and then in addition to that, protein overexpression, which we've tried to take a look at also. And so the next few slides are going to try to summarize some of these data. So unfortunately, MET protein expression doesn't appear to predict for response to MET inhibition. This we know formally from David Spiegel's presentation last year for the MET-MAP study, the randomized phase 3 study of erlotinib with or without onartuzumab in patients who had high expression of MET. There was a trend towards improvement in overall survival that was not significant, however, and then the PFS and overall response rates were not different, which was a little bit surprising given the promising phase 2 data. MET amplification may predict for response to crizotinib. Ross had presented these data last year. I'm sure there's going to be an update relatively soon. But again, the ever ongoing phase 1 trial of crizotinib has an arm for MET amplified non-small cell lung cancer patients where there was initial stratification for low amplification, intermediate amplification, high amplification groups. And at the presentation last year, 13 patients were treated with 4 partial responses, 1 in the intermediate group and then 3 in the high group. And this study is ongoing as well. And then more recently, we and others had reported some clinical efficacy data targeting MET exon 14 mutations in non-small cell lung cancer. And so this has been known about for quite some time. The mutations themselves affect the splice acceptor and donor sites that flank exon 14, leading to alternative splicing, so skipping of exon 14, which deletes the juxtamembrane domain that this encodes for, and subsequently leads to loss of CYPL E3 ligase binding. Again, Ravi had gone over the biology yesterday also. So overall, this stabilizes the MET protein, leading to overexpression and hyperactivation of downstream signaling. So Ravi's group first characterized this in small cell lung cancer in 2003, as well as in non-small cell lung cancer in 2006. And in terms of the oncogenicity of this event, this was previously reported by Kong Beltran in 2006, with some initial targeting with MET-MAB presented as well. The mutations do occur in about 4% of lung adenocarcinomas. This is from TCGA, as well as some data that I'm going to show next. As Neil Hazen mentioned yesterday, there are these cryptic exon 14 alternative splicing cases that we see in TCGA lung adenocarcinoma that do not have a DNA mutational event that's present, suggesting that there may be other mechanisms that are leading to exon 14 skip that sequencing, at least DNA sequencing, is not going to uncover. So the frequency actually may end up being higher than this. And these also appear, we know from Balazs Halmos's group, to be frequent in sarcomatoid carcinomas, happening about 30% of these cases, which is, at the end of the day, phenomenal if this ends up holding true, since these tend to be refractory to all treatments that we provided. So as an overview for the mechanism itself, again, in terms of immediate post-transcriptional events, the pre-mRNA has to be concatenated down, which occurs through the use of the spliceosome, again, an acceptor and donor site that flank each exon. There are canonical sequences for the acceptor and donor sites that, when mutated, lead to dysfunction. And as an example, sort of a graphical example, donor acceptor sites that flank exon 10, 9 and 11, which will lead to, which will lead to deletion of the intronic sequences and placing 9, 10, and 11 in frame. If you have a mutation, in this case a donor site mutation, then you get alternative splicing using either an upstream or a downstream acceptor or donor site. And in this case, it leads to deletion of exon 10 of this make-believe RNA. So our own data of 678 sequenced non-squamous non-small cell lung cancers over the past year at Memorial using our targeted exon sequencing platform has detected 27 MET exon 14 splice site mutations for 4% frequency, again, similar to TCGA. And we presented some of this at World Lung in terms of the clinical characteristics of those 27 patients. Some of the things that were noteworthy was a slight predominance for never smokers at 56%. And in terms of the histology breakdown, 70% with adenocarcinomas, 26% of our patients had sarcomatoid carcinomas, and the one patient had a squamous cell cancer, which I'll show in a little bit also. We had quite a number who were treated either off-label or on protocol with crizotinib, and these data I'll show in a little bit also. This is a graphical presentation of the location of some of these events that we see, which range from simple missense mutations in the intronic donor and acceptor site sequences or deletions of these areas as well. Importantly, we have cases also that delete or mutate Y1003, which is the key tyrosine residue that binds to Sybil. So this also we have shown leads to efficacy in terms of targeting with crizotinib. Some of the other things that we went ahead to show was that these splice site mutations do lead to overexpression of the MET protein. So this is an example of 3 different patients, all of whom had H scores of 300 for MET, as well as a deletion in terms of RNA expression. So this shows a group of MET wild-type patient samples. On the top right, the black circles, and then on the bottom left are our cases that we where we perform nanostring for exon 14 normalized exons 3 and 4 with H596 as a control cell line, showing loss of exon 14 in these cases. This is an update from World Lung. So we now have 8 patients, non-clinical trial patients, who I can freely report who have been treated with crizotinib. The partial responders are 7 out of the 8. One of them, which I'll show in a little bit, is interesting, had stable disease on cabozantinib, but then quite a brisk response on crizotinib on progression with cabo. And then the other interesting case is a squamous cell cancer in red with a MET exon 14 splice site mutation who had primary resistance. This is a waterfall plot, not much of a waterfall, but for what it's worth, a waterfall plot of the responses that we've seen. Again, that one patient, interestingly, who had squamous cell cancer did have this variant present on sequencing. We went and we're in the process of doing some additional studies. The first one that just came back was the H score for MET, which actually 0. So MET was not expressed in this case, which is pretty interesting. We're going to go ahead and check the RNA on the leftover tumor material and then resequence also to make sure that this was actually present. And then some examples of the responses, again, that we've seen to crizotinib. This is a patient who had a response in the lung as well as her liver lesion. This is another recent patient who had quite a good response. This is a 5-month scan post-crizotinib. And then the interesting case of a patient who had stable disease for some time, had a complete persist response, but stable disease for some time on cabo, eventually had disease progression, came off, and then had a relatively brisk response to crizotinib, which is being sustained at this point also. So in summary, MET exon 14 splice site mutations do appear to predict for response to MET inhibitors. They occur in about 4% of lung adenocarcinomas by DNA sequencing. Again, RNA analysis may uncover additional cases in the future. The resistance mechanisms, of course, are relatively new or largely unknown. Some of the things that have come up are G1S checkpoint aberrations as resistance mechanisms in some of the samples that we've identified. The one non-small cell lung cancer cell line that does have a MET exon 14 splice site mutation also has a PIK3CA E545K mutation, which actually causes resistance to crizotinib. This was previously reported a few years ago, actually. And so this likely also is a cause for primary resistance, at least in that cell line. And again, the clinical trials for this are ongoing, and I'm sure we'll hear an update for the formal data for this at ASCO next year. That's it.
So for this patient, do you think antibody approach will work, or
Yeah.
should have to be small molecule?
You know, it's a good question. In theory, it should work. You know, one of the possible mechanisms of resistance, again, so crizotinib, which is really the only drug for which we have data so far, binds the inactive conformation. And so one of the concerns is, you know, if there's a lot of HGF floating around and these you know, ligand bound to the receptor, then maybe this could potentially lead to resistance. One wonders whether or not dual inhibition strategy would work. Certainly single agent in terms of the cell line data was shown to have some modest efficacy. This was back in that Cancer Research article from 2006. The problem with that is that the model also had that PIK3CA mutation present. So I do think as a result that antibody-based strategies are not dead in this sphere, that these are going to be important considerations going forward also.
Thank you so much. Quick question. Can you comment on how you think amplification of MET plays into responses with that 14 scale?
Yeah, so most of the cases we treated do not appear to have MET amplification, at least by sequencing call-out. There were 2 out of the 7 responders who did have a MET amplification by sequencing. I think the normalized read was at 3 for one case, and then 6.8, which would also be high for that latter case. So I do think that there's probably a lot of non-overlap in these cases. So that's sort of the general, thought. Right. Yeah, that's exactly right.
Well, 3 to 4% is a sizable number of percentage of patients. Besides the trials you're doing at Memorial, are you aware of any large trials that are being done, or not large, but widespread trials done with the space?
So, right now the Pfizer study with crizotinib, has a leg up on everyone basically. It's always been open. And so there are a number of other companies that are interested in the space where we will begin to see trials emerge relatively quickly because these MET inhibitors have been around for a while also. So I do think we'll begin to see additional trials opening up.
And just do you know anything in other tumor types for this same that you think this may have a role?
Yeah, so MET exon 14 splice site mutations have been found in other malignancies. Neil had mentioned, or at least shown in the TCGA head and neck data that they had, I think, 1 case of an exon 14 splice site mutation. There is a good model, gastric cancer cell model, HS746T, that has an exon 14 splice site mutation, which is responsive to MET inhibition also, and this has been published before. So these do happen in other malignancies at relatively low frequencies. The best paper to take a look at is the cancer discovery paper that came out also a few months ago, where sequencing was performed by Foundation Medicine, and they do sort of a comprehensive survey of that. So.